Good afternoon, my friends. Happy Wednesday. The doctor's in the house. Welcome back to another episode of To Your Health with Dr. G on such a great day. And I tell you what, as always, the show is going to be fierce. Here we are back here, building trust and delivering truth. Every week on the show, I just love my guests. I love talking about health because really, it's our foundation for everything. As a physician, I want you to be healthy. I want you to live your life's purpose. Again, we can never lose that broader perspective of what we want to do. So each week on the show, I love talking about great topics with awesome guests. Today's show is no different. We're breaking it down today. Rheumatologic conditions made ridiculously simple. My name is Dr. Mark Gomez. I'm a board-certified internal medicine physician practicing at Edward Hospital in Naperville, Illinois. I'm also a member of the American College of Lifestyle Medicine. So it's all about lifestyle. The things that I tell my patients all the time: move more, eat better, stress less, get some sleep, because the latter part affects everything that we do. But I'm so excited to welcome you guys back to the show. Check me out on my website, www.drmarkgomez.com. We're broadcasting live here at Intellectual Radio Studios. We're also on Facebook. Welcome back, everybody. Again, today's show, I'm so excited. You guys are going to meet my guest in a few moments. She and I go back, a great friend and colleague, and I cannot wait for you guys to hear her story. And again, as clinicians, we always talk about what's important for people. Again, it's all about the what you're trying to do with your health, why you're trying to do it, and then how we're going to get there. We want to navigate you in your life's journey, your health journey from point A to point B, and have it be full of as many successes as possible. And remember, at the end of the day, talk to your doctor. I think at the end of the day, we always say, I tell this to my patients, there's no such thing as crying wolf. I'd rather have you tell me something than not tell me anything at all. I'd rather give you reassurance and then get you back into your life and everything versus delaying things. Again, prevention is the solution, and certainly being proactive versus being reactive. Again, so I'm so excited. Rheumatologic conditions made ridiculously simple. I just love that. You guys are going to hear about it today. We're going to talk about, it's really a show for you. All these shows are for you at the end of the day. Me and my expert panelists, we want to give you guys the tools you need for success in everything that you do. But today's show, when I was coming up with this idea, I was like, all right, I get asked so many questions by my patients. It's kind of like a frequently asked questions. And I get asked so many things, and I always say, all right, let me take a mental note and say, all right, let's write that down. So today's show is for you. It's like a grab bag, a mail grab of answers to your commonly asked questions, and no difference than what we're doing today on rheumatology. So before we get into everything today on the show, I want to read you a quick disclaimer. The content of To Your Health with Dr. G is for informational and entertainment purposes only, and that the content is not intended to be a substitute for professional medical advice, diagnosis, and/or treatment. Further details can be found at www.toyourhealthwithdrg.com/disclaimer. So here we are today. We're talking about rheumatology, and again, that's a word that I don't know if everybody understands it. We have our perceptions of it. If you do, a lot of people think it's just arthritis, but it's more than that. And so we're going to talk about that today. But we're going to get into a lot of things. I'm actually going to be debuting a new segment on the show today on Tier with Dr. G called Is It True That? And we're going to fill in the blanks. Of course, towards the end of the show, we're going to do my coveted myths versus facts that we do every week. And it's all about setting the record straight. I want you guys to be empowered with the information that you receive. And the best thing you can do today is share the show. Any loved one that you have, somebody that's on a journey that just needs more information, again, use me, use my experts, their credential and what they do, their passion, what they do to help you be a better you. So don't forget about that. So what I want to do today, of course, is I want to introduce you guys to my amazing, I like saying that word, amazing, my amazing panelist today. And she doesn't know, but I'm actually wearing socks today that have shapes of bones on them, because we're talking about rheumatology. And so I'll have to show her my socks after the show's over. She hasn't seen them yet, but I did this for you for a reason, because we're going to be talking about some joints and some bones and other things like that. But what we're going to do today is we're going to really center the conversation around the most common rheumatologic conditions that certainly are out there. And of course, it's my show, I get to choose those conditions. But I want to introduce you to my good friend. So let me read the credentials, because her credentials run deep. I want to welcome to the show Dr. Nisha Da Silva. She's a board-certified rheumatologist. She's with Edward Elmer's Health. Check her out, www.eehealth.org. Dr. Da Silva, welcome to the show.
Thank you. Thank you for having me.
I'm so excited to have you here.
I'm excited to be here.
I know. I was like, this is like the universe coming in. I'm like, okay, we connected, and let's do this on radio.
Yes.
Because why not? You're so passionate about what you do.
I am.
You take such good care for my patients, and it's true. She's seen a ton of my patients.
Thank you.
Check her out again, www.eehealth.org. rheumatology.org. So Dr. DeSilva, let's do this. Tell us a little bit about your background. Where did you go to medical school?
Sure.
Where did you do your residency training? And what's kind of your thoughts of just general opening remarks about rheumatology in general?
Sure, yeah. So I actually grew up in the area. I'm from Darien Downers Grove. I went to undergrad in St. Louis, and then I went to med school at Midwestern University or Chicago College of Osteopathic Medicine. From there, I did my internal medicine training at Franciscan St. James, so that's in the south suburbs, so Olympia Fields and Chicago Heights. From there, I did a chief. I was co-chief for my third year of internal medicine. It wasn't an additional year, but it was built into my third year of residency, and then I went on to do rheumatology. And I stayed at the same program, but it was based in Indiana, so kind of Dyer, Munster area. And then from there, I was kind of ready to come back home, and so now I've been at Edward Elmhurst Health or eHealth since September of last year, and I have 2 offices in Naperville and Plainfield, so I kind of provide care for a little bit wide demographics and area.
Yeah, you really do, and you're so passionate about what you do, because again, I hear this back from my patients, and they're like, oh my gosh, Dr. G, thanks for recommending Dr. DeSilva, and really, I think we have such a great professional relationship in that you all, I mean, first of all, when I read your letters to me, I feel like I'm learning so much. I feel like I should get like what we call continuing medical education credit, because the knowledge is deep, so I want to pick your brain today, and I'm going to contribute as well too. I'm not just going to pick on Dr. DeSilva, even though she knows so much. I'm going to try to contribute where I can, but that of course means translations that I'm going to get the easy questions and give her the harder ones. But no, thank you for coming out today.
Of course, thanks for having me.
And so I want to kind of set the record straight here. You know, when it comes to rheumatologic conditions, there's so much misinformation out there, and really I think we have to definitely set the record straight. And it's on shows like this that we're able to do so, because we certainly, you and I, when we talk about our mutual patients, we want them to do so well. And so we know that as a fact, more than 50 million Americans suffer from rheumatologic conditions, and there's actually over 100 different types of conditions. Now we're focusing it down to 5 things today, and the 5 things will be rheumatoid arthritis, osteoarthritis, fibromyalgia, gout, and then lupus. But again, I want to, and that's how I kind of constructed the program. But it's okay if we get a little bit going down one way, we'll answer those kind of questions. But this show is again really for you about a grab bag. But I want to ask this to you first. Rheumatology. What are kind of the things you hear when people hear the term rheumatology or rheumatologist? You know, how do you just tell people what you do?
Sure. So a lot of times when I tell people I'm a rheumatologist, they look at me and they kind of nod and they're like, so what exactly is that? Is that like a bone doctor? Is that an arthritis doctor? And yes, to a certain extent that is what rheumatologists do. But we also focus on not just the bones itself. So it's the musculoskeletal system, and to a certain extent even the vascular system. So we treat what's known as autoimmune conditions. So essentially when the immune system, which normally is supposed to help you fight infections and kind of recover after stressful events, starts to go haywire for whatever reason and starts to attack your own self. Now, whether that's the bone, the skin, that's where people can get joint pain, as well as even the muscles. I mean, it literally these conditions can affect head to toe. So it gets difficult to explain what exactly we do, because we do kind of have to know the body head to toe to help patients kind of deal with these conditions.
You have to know everything. I may add organs and organs in there too. I mean, you guys just do so much, and I'm glad, like, when I get perplexed or run into a wall working on a patient, I know that I can have trusted people like you, professionals that can just say, hey, this is maybe what it kind of sounds like, and let's work together and let's help our patients feel so much better. So I appreciate it. So each week, when we do this show, we have something called the chief complaint. And obviously the chief complaint is when people come into our office and say, hey, I'm here for such and such reason. So the chief complaint, aka the question of the hour, as I was talking about a little bit earlier about some misleading information. So here's the question of the hour. How can we better understand rheumatologic conditions in order to separate fact from fiction? And so I just think it's awesome. So let's talk about this. We're going to get right into it
Sure.
because at the end of the day, people want answers. Now, again, this is not a substitute for professional medical advice. I said in the beginning. If there's any concerns that you have out there, I want you to talk to your doctor. If you don't have a doctor, find a doctor. But you want to talk about everything with your doctor. I don't want you searching Dr. Google, by the way. We're talking about your regular doctor, real doctor. But I don't want you guys searching things that are out there and getting the wrong information. That's why, again, we have these kind of shows, these forums to talk. And I will say that, I certainly don't know all the answers to everything in health, and I don't think anybody does.
Right.
But we want to use our knowledge and our education and our tools and our resources to help you, again, be a better you. So here we go. We're talking about rheumatoid arthritis, osteoarthritis, fibromyalgia, lupus, gout. These are kind of things I want to focus on. But before we focus on the mailbag that I have for you as promised, maybe we can just start with a little overview. So,
Sure.
Dr. DeSilva, can you kind of give us like an overview of like what is rheumatoid arthritis, RA, and then we'll say like osteoarthritis. We'll just go one by one with these kind of things.
Yeah. So I gave a talk, actually, like a lunch and learn a couple months ago. I think it was over the summer. And the best way that I approach rheumatologic issues is kind of outside in versus inside out. Okay, so you have to think of autoimmune processes, where it's the immune system attacking the body, versus kind of wear and tear and things that we might be doing to the body. So that's a perfect way, because a lot of times people will come to me and they say that their hands hurt and that they have to have rheumatoid arthritis, but that's not the case. So osteoarthritis or degenerative arthritis or wear and tear arthritis, that's all one category. Now that's much different in terms of the pathology and the pathogenesis from rheumatoid arthritis, lupus, and some of these other ones that we might not be talking about today, but like psoriatic arthritis and ankylosing spondylitis, which are more inflammatory and autoimmune in nature. It's really important to tell the difference between these two, because the treatment is completely different. So for wear and tear arthritis, there's not a lot that we can do for it, unfortunately, in terms of slowing the progression, in terms of medications. Now, there's a whole slew of lifestyle things that I think we'll kind of get into hopefully later. Versus for autoimmune conditions, we really need to target the immune system. So these are stronger medicines that can put patients at risk of infection and all these things, but they're indicated because that's how you treat the disease. And so, risk factors for osteoarthritis are going to be somewhat family history, but definitely weight, lifestyle, trauma, injuries, things like that. So any insult to a joint can potentially lead it to have arthritis down the road, and that's not necessarily autoimmune in nature.
Gotcha.
And then when we talk about rheumatoid arthritis and lupus specifically, so that's where there are specific triggers on the immune system that cause this whole cascade of inflammatory cytokines and a bunch of other proteins and things to attack different parts of the body. Now, rheumatoid arthritis, like it sounds like, classically is the joint. So it's typically going to cause stiffness in the morning, and it's not just stiffness that lasts for 5 minutes. I mean, sitting here when I get up, my back's going to be a little bit stiff, maybe a little bit in my knees, but it's not something that's going to be interfering. Now, patients with rheumatoid arthritis classically have that stiffness that lasts for like at least 30 minutes. So patients can take up to 2 hours, even longer, to really get going in the morning. And that's because of that amount of inflammation that's in their joints. And then in terms of like lupus is a really hard disease. It can be really hard to diagnose because that's one that classically affects head to toe. So you can have just skin involvement, you can have just kidney involvement, you can have involvement of the heart, the lungs. Some patients just have kind of a hodgepodge of where they have a little bit of joint pain, a little bit of skin rash, a little bit of this, that, and that. And so it gets very difficult to treat sometimes because it depends on the severity of the disease and how it's manifesting.
That was awesome. Great breakdown, by the way. I love it. What would you say this? When I see things, a lot of times people may come to me late in the game. They might have had symptoms for months on end, and then they finally say, or fair enough, years, and by the time people maybe see you, and they're completely frustrated. And I guess the message that I always try to get to my patients is, I want you to say something soon. I always tell people, you give something a few days. I mean, we're human, let's be honest. But if something's still nagging after a few days, then I want you to start thinking about it more. But I think the point that you're saying is if you delay that diagnosis, first of all, yes, they might be more progress in their disease etiology, in their disease course, the burden. But I think about the things that are missed while somebody's going through those burdens. The fact that it can take away from your lifestyle and being active with your family and seeing your loved ones, or doing certain things because you're in pain or something doesn't move. And I really want people to know that it's okay to speak up, because we want you to speak up. That's why we're here. So, but because by the time they come and see you, you might be talking just straight medicines,
Right.
And I might be talking lifestyle from my end, and you probably be reiterating lifestyle, but they might be coming at you and you're saying, all right, this has been going on for a couple of years now, and maybe some tests are done, and you're like, oh my gosh, we need to really start talking about medicines to make you feel better. And I know a lot of people don't want to necessarily jump to medicines and say what I do, but they kind of say, well, you've been feeling like this for all this time, we got to do something.
Right. 100%. And I mean, I still try to incorporate other lifestyle changes, because even if we're going to target the disease with medications, you still want to make sure you're exercising regularly, you're eating healthy, you're cutting out some bad habits such as alcohol as well as smoking. I mean, these are all things that will contribute to just how your overall health will be, and you want to start at the best kind of baseline. That way from there we can only get better, because unfortunately with these diseases, if we don't control it, there can be progression, there can be increased disease burden, and there can be permanent changes from it. Once those permanent erosions or breakdown of the bone happens, we can't reverse that, but we try to slow the progression and kind of like you said before, live your best life.
Yeah, live your best life.
That's the goal, and that's actually why I went into rheumatology. Was the quality of life is really what my goal is, and improving in my patients.
Excellent. Can you break down briefly gout and then fibromyalgia?
Sure. Yeah. I'm sorry.
Yeah. Oh no, that's all right. No, this is good.
So gout is it's one that's kind of, I know I said inside out versus outside in. It's kind of one that's right in the middle. So gout, there is a hereditary sort of predisposition. So if there's family members who have a history of gout, you might be at increased risk of having it. What it is that you have high levels of uric acid in your blood. Okay, and now this can be, like I said, there can be some genetic predisposition, so some people who eat very clean can still get high levels of uric acid. But what happens is when you get these uric acid elevations in your blood, whether it's due to your kidneys not being able to filter it out, or you just have an overproduction, can even happen in some people who have cancer because of that high cell turnover is what it's called. So when you have all these uncontrolled cell growth, which can lead to tumors and whatnot, that can cause this high levels of uric acid. And then the main one is diet. So eating food that's high in purines is known to kind of cause the gout. And what happens is you get these uric acid crystals that deposit within the joint space itself, and that causes robust inflammatory response. You have all this inflammation. That's why people can barely tolerate even a sheet over their toe. That's like the classic sort of scenario, because of how sensitive it is and how inflamed it is in that joint. And what happens is when that goes chronic, when that gets into the chronic phase and it's not treated, there can actually be breakdown of the bone itself and then chronic changes there. You can even get what's called tophi, which are these almost nodules or bumps that form over the joints, which are full of this uric acid. And then that can make it hard to even have regular shoes fit normally.
I think about even like those cases where you see somebody with these bumps, this tophi that talks about they get infected, and that can lead somebody to be very sick. That's what you want to do.
And it's not just over the toe. So that's just the classic place, right? The first big toe is kind of what's classic that you see pictures of, cartoons of, that date back into I don't even know how long ago. But it can affect I've seen it in the hands, I've seen it in the elbows. I mean, you can even get, with really high levels, you can get skin deposition. And so you can get little white crystals that form under the skin as well. I mean, that's an outlier, but that can still happen.
Right. You mentioned, Dr. De Silva mentioned the word purines, and purines are natural substances that are found in certain foods. So we think about classically as in organ meat, like liver, or sometimes even some fish products, like sardines, for example, or anchovies. And then they basically, purines form uric acid crystals. And again, of course, those crystals are the things that, as Dr. De Silva eloquently mentioned, that they get deposited, lodged into those joints and cause a ruckus, without a doubt. And statistically, I know, I mean, there's obviously millions of people that suffer from gout, but I believe it's statistically one of the most common forms of arthritis in men over the age of 40.
Yes. So it happens more often in men for sure, but that does not mean that women are not
Okay.
able to have gout. The thing is that it typically happens in postmenopausal women, because what happens is estrogen can kind of help protect and kind of help with the whole, I won't get into the nitty gritty of the physiology behind it, but estrogen is somewhat protective against the development of gout due to how the uric acid builds and how it gets processed.
Oh.
So that's why you don't normally see women who haven't gone through menopause have gout. But anyone who's no longer getting their period, their estrogen levels are different, they can get gout. So that is somewhat of like a misconception that it's only in men. I treat many women who have gout as well.
Thank you very good. Thank you for clarifying that one, because I agree. I think that's really the public sentiment on that one. So anybody does not discriminate without a doubt. And lastly, let's do just a quick thing on fibro.
Yeah, so that's definitely a hot topic right now. It is getting more and more diagnosed, I feel like. It's not a true autoimmune condition, and it is not lupus. I think it's really important to clarify that, and they're kind of mutually exclusive, meaning just because you have fibromyalgia does not mean you'll develop rheumatoid or lupus or another autoimmune condition. It is more found in patients who have a history of depression, anxiety, and PTSD, but you don't need to have those conditions to have fibromyalgia. A lot of the symptoms with fibro can be misconstrued and do overlap with lupus. So you can have kind of chronic fatigue, general just unwell feeling, kind of diffuse pain, but the pain is not necessarily just over the joints. It can be in the muscles and maybe even over where tendons can be, and it definitely is more aggravated by lifestyle sort of things, right? So lack of sleep, which you mentioned before, that is a
Sleep affects
huge,
everything in the body, every body system.
Exactly. It's a huge reason as to why. I mean, if you think about it, if you don't sleep well, let's say you do 2 nights in a row where you know, whether it's you're caring for somebody who's sick or you're sick yourself and you're just not sleeping, think about how you feel after that. You feel so run down, your whole body just aches. That's kind of like fibromyalgia, but on a daily basis.
Wow.
So you have to think if you're not resting, or kind of think about your phone. If you're not charging it while you're sleeping at night, it's going to be on low battery. It's not going to function throughout the day the next day. It's the same thing, not same, but very similar with fibromyalgia. If you don't let your body rest, you need to be getting at least 6 to 8 hours of sleep at night. And that's like quality sleep.
Yeah.
So not an hour here, waking up, looking at your phone, going back to bed, an hour there, and it's spread out. It needs to be 6 to 8 hours of quality sleep.
Yeah, I always tell my patients, we live in a society where sleep deprivation is pervasive, without a doubt, and certainly in adults, and we've seen it in the kids. So we did a sleep show a few weeks ago and broke that down, and yes, touching base on the importance of sleep, just the restorative things that are made when you sleep, and we just don't set out time for that one. I mean, we're busy, but as my good friend
It's
Dr.
not
Flores said
important.
at that time, he said, compared to Americans 100 years ago, the current day American gets 1.5 hours of sleep, of less sleep per night than they did 100 plus years ago. And I go, wow, you know, sometimes when you get that lack of sleep, you go, I would love to have a 1.5 hours more sleep, and how amazing you feel after that.
Yeah.
So without a doubt, when it comes to lifestyle, so thank you.
So the sleep definitely helps with the fibromyalgia, as well as exercise. So a lot of times people get caught up because they feel so horrible that they can't exercise. But exercise is so important when it comes to fibromyalgia. Regular routine physical activity will actually help the pain get better. So it's not all medication, and patients who I see for fibromyalgia see that I do a multi kind of disciplinary sort of attack of the disease. I'm not just throwing medicine, because if we're not getting that quality sleep and not regular exercise, it's kind of a drop in the bucket is what I say, that we're not making like headway when we're talking about the treatment.
Yeah.
In terms of medications, it is treating that underlying depression, anxiety, or PTSD. So there are medications that can help with that help with both the depression, anxiety, as well as the pain. And then there are some of these nerve kind of medicines, because it's thought to be somewhat of an overactive nerve syndrome.
Central nervous
So
system
that's where
disorder.
like gabapentin or Lyrica, you can see a lot of commercials for that on TV. That's where those can play a role. But again, I don't just start and throw medicine at patients. I think it's really important to know the lifestyle modifications, making sure you're eating healthy, as well as getting that proper sleep and exercise.
Excellent. Well, thank you for breaking down these overviews. So we're going to get right into it, some of these grab bag type things. So I want to go right here. I'm going to help out too when I can, but again, this show's for you. So here we go. I'm debuting something new on To Your Health with Dr. G. Here we go. Is it true? So is it true that... I'll take the first one. Here we go. These are commonly asked questions. I want to give answers. So, is it true that we should eat fish to curb inflammation, aka salmon, tuna, mackerel, and sardines? I would say, of course, when we're looking at the anti-inflammatory, we're looking at inflammation fighting omega-3 fatty acids, and so that is usually part of a typical diet. We're talking about an anti-inflammatory diet, but this is also getting away from some of the challenges with the typical American diet that can actually promote more disease. And I would actually take this a step further, because you guys have heard me talk about the benefits of whole food, plant-based approaches. You can unlock so many antioxidants and anti-inflammatory properties that are found in those key minerals that are found in whole food, plant-based nutritional approaches. All right, so here we go. Dr. DeSilva, I'd like this one for you. Is it true that wearing a copper bracelet can cure arthritis?
So that is false.
Please explain.
Wearing a copper bracelet, I actually did a quick literature search on this, and there were studies that date back into the 70s about this. So copper bracelets, as well as these magnetic strip that you wear on your wrist, was studied to see if it would help with the arthritis. It has not been shown to be beneficial. It does not slow the progression of arthritis, and it does not necessarily reduce pain scores when compared to like placebo, meaning the lack of actual intervention. Now, I tell my patients, if it makes them feel better, there's not necessarily going to be any harm with it that we're aware of. So I would say if it makes you feel better, that's fine, but don't expect it to make a difference, because I don't think that it will.
Yeah, it's definitely a marketing ploy. There's no doubt about that. I'm going to take this next one. Is it true that kids don't get arthritis? I'm going to just use this in the compound of rheumatoid arthritis, for example. So we know typically that the age range is somewhere between 30 and 60 for rheumatoid arthritis, so inflammatory-based arthritis. But the reality is that young teens, young adults, teens, and children have been shown to have this. And I believe the statistic that came out of Northwestern, out of their medical center, said when I mentioned at the beginning, there's over 50 million people in this country with rheumatologic conditions. I believe the number for pediatrics was over 300,000, and that number might be underreported because people are not still going to the doctor. So, anyways, all right. So here you go, Dr. DeSilva. I'd like this one for you. Is it true that side effects are too risky to justify medications and when you're treating with rheumatoid arthritis?
False.
It's false.
Absolutely false. So obviously, every single medication that you're going to take, even supplements, are going to have potential side effects. You have to kind of weigh the risks and benefits of it. Some of the side effects from these medications could actually be linked to the underlying disease itself. So rheumatoid arthritis itself has been linked to having lymphoma and some hematologic malignancies. So I hear patients all the time that say, well, these medicines can cause cancer. I don't want it. I'd rather have the rheumatoid. But having that overwhelming inflammation from the rheumatoid arthritis itself can also lead to potentially cancer, as well as permanent damage to the body. So, no.
All right, thank you. Here we go. I'm going to see if I can take this one, but I might have to have you give me a little assist on this one. That's okay. I'll admit it. That's why Dr. DeSilva sees a ton of my patients. If I get to a hurdle, I just send them over to her. It's great. It's great. That's why we work so well together. Exactly. All right. So is it true that smoking does not increase my risk for developing an autoimmune disorder? I would say smoking does increase risk for a lot of things. If you're worried about just getting an autoimmune disorder from smoking, then we got to get our priorities straight, because we're looking at, obviously, tobacco use. When I think about it as me, as I'm prepared, I was talking off here with Dr. DeSilva that I'm going to be taking my lifestyle medicine boards next year. We know that tobacco use is a number one underlying risk associated with death in this country. Yes, we know heart disease is number one cause of death, and cancer number two, but smoking, tobacco use is the biggest risk factor that's modifiable. And so I would say, yes, I don't know the statistic in all honesty on increasing autoimmune disorders, but
it's there. It's there for sure. So it's an independent risk factor for developing rheumatoid as well as lupus. And studies have actually shown that active smoking when on therapy for an autoimmune condition can make you not respond as well to medications. So I have some patients who it's just difficult to control their disease, but they're still actively smoking. So we're having to jump from one medicine to another, to another, to another. They're not feeling better, and it's I think in part due to their active smoking. Yeah. I mean, aside from the lung cancer and all these other things that you're at risk for, there's just no health benefit to it. So I don't I would just recommend stopping.
Yeah, one of the things I tell some of my patients, if they are going to see you and they have these focus, I tell them straight up, I go, listen, you're going to see a rheumatologist, but I can guarantee you this, she's going to tell you to stop smoking. I've already told you to stop smoking. So we want to work together. There's different options out there when it comes to different therapies. You know, there's cognitive behavioral therapy, there's medications, there's so many different things, but we want to talk about the fact that it's very dangerous. All right, here we go, Dr. De Silva. I think you answered this one, but I will say it anyways. Is it true that exercise is the single most effective treatment for fibromyalgia?
So this is true-ish, because I don't want to
I
say
like
it's
ish. I like that.
it's not the single most. You know, you never want to say the most or the worst kind of thing.
Gotcha.
But it's definitely very crucial, and it's one of the main pillars of when we're talking about the pillars of treatment for fibromyalgia. So like I said, exercise is good because it also, not only is it getting you moving and kind of getting you active, but it's also helping with endorphins and kind of helping you be happy as well. So it's helping with the physicality of it as well as the emotional aspect of treatment.
Excellent. Here we go. I'm going to take this one. Is it true that everyone with a rheumatologic condition needs to be on prescription medication? That is a false. It's not true at all. You know, one of the things we talk about certainly is the lifestyle, and we talked a little bit about it. We'll probably get into it in a few more because I got some other of these is it true sections. But the reality is your lifestyle really sets a foundation for everything, and some things may be modifiable. There's other obviously there's plenty of non-pharmacologic options. We haven't even talked about potential use of mind-body practices like Tai Chi in certain conditions, or Qigong, or progressive relaxation, or hypnotherapy, or other kind of things that are out there. And so we want people, certainly when I see them in my practice, and if they're working with you, I know you've already given them the lecture, but I say, let's continue to look at what we can support from lifestyle. Can we modify certain things and not necessarily saying, oh my gosh, you're going to be on these heavy-hitting prescription medications.
Right, 100% I agree.
Excellent. So here we go, Dr. De Silva. I like this one. Is it true that green tea may slow joint damage?
False. I really have not heard of that. I know that there are antioxidants in there, so you would think that it could somewhat manage inflammation to a certain extent, but it has not been shown to truly slow progression of arthritis or prevent an autoimmune condition.
Yeah, there's a theory out there that says that by doing green tea, there's certain molecules within green tea that block the production of molecules that promote joint damage, and I agree. I just haven't seen that out there, and I don't even know how you would design a trial, a green tea trial.
And I mean, there's so many products out there that it'd be hard to know what level of these, anti-inflammatory molecules are being in the different types of tea.
Excellent.
Different types of green tea.
You're hitting the head on the nail, without a doubt. Here we go. I like to do this one. I'll take this one. Is it true that fibromyalgia is a psychologic problem and not a real physical illness? That's one of the biggest myths out there, and it's false. I mean, fibromyalgia is real. It's a chronic disorder of the central nervous system that manifests itself with pain and a lot of other symptoms, including profound fatigue. But it is real. It is not a psychiatric illness. Here we go, Dr. De Silva. I like this one. I put this one in here for you. I like this one. Is it true that any doctor can treat my rheumatologic condition?
False. So it depends on what rheumatologic condition we're talking about, right? So, wear and tear arthritis and gout to a certain extent can be managed by primary care and podiatry, depending on the severity of the disease, as well as orthopedics. There are multiple other specialties that can control it. But definitely, I mean, rheumatoid arthritis, some of these more autoimmune conditions, lupus, you really need to see a rheumatologist. We feel more comfortable. We're trained in these medications and being able to prepare for potential side effects that can happen and just be able to share that knowledge with patients. That way they're not just started on. I mean, I've seen some interesting, I'll say, combinations of immunosuppressive medicines or medications to suppress the immune system in these autoimmune diseases. Then I'm like, how did they think of this concoction? And it could almost put patients in more risk and more damage than what's really appropriate. So
excellent. Thank you, Dr. Silva. You guys are here. We're checking out here. This is awesome. We're having a great discussion. We're here at Intellectual Radio Studios. You're watching us here live on Facebook, so thank you. Let's keep going with some of these things. And by the way, if you guys have any things out there, I know some of you have already chimed in on Facebook Live. If there's any kind of things that we're talking about, common questions, and we're trying to get some answers. But if you have a question, go ahead and throw it out there. We may be able to get to it if we can. Here we go. I like this one. I'll take this one. Is it true that only wealthy and obese people get gout? And the answer is no. Gout does not discriminate. Dr. De Silva mentioned that many women, and we didn't even talk about socioeconomic, but I think that kind of came out of the fact that people that ate those rich foods, those big animal proteins, the liver and the various kinds of fish, and drink the beer and all that kind of stuff versus the more socioeconomic disadvantage.
Right.
And skinny people will get that stuff, but I'm sure you've seen gout in
Yes.
skinny people
Yes.
and in
Skinny,
people,
athletic, otherwise healthy individuals can still get gout. And it comes, like you said, so back in the day, it was royalty that were able
There
to
you
eat
go.
the red meat, you know, the organ meat and things like that, and had more alcohol accessible that had it. So it was previously thought that it was only a wealthy man sort of disorder, but obviously things have changed since hundreds of years ago. And also high fructose corn syrup and like those very sugary beverages, they're all the rage now. I mean, everybody's got some sort of pop or something or you know, things that can definitely cause it to be worse.
And I used to work for a doc, and this is a long time ago, back in my days at Loyola. I'm dating myself, it is what it is. But he used to always say, the purest will drink water. You know,
Yes.
that's all you really need.
Yes.
But big style marketing has kind of conditioned our brains to do the things, the Pepsis, the Cokes, and all that kind of
Right.
stuff.
Right.
That actually can certainly be disease promoting. All right, here we go. I like this one. This is for you, Dr. De Silva. Is it true that arthritis is brought on by weather changes?
False. So arthritis itself won't be brought on by weather changes, but I know that we've all had our grandmother or mother say, oh, I feel like it's going to rain today. I feel it in my knees. And there is somewhat of science behind that, okay? So what happens is that there's changes in the barometric pressure, and that can cause, there's a little bit of fluid in all of your joints, and that can cause that sensation of the pain. So you might have increased aching with changes in the weather, but it won't be caused by the weather itself.
Excellent. I know. I always think about the patients that I have, or even some of my family members. They're like, "Oh, it's gonna rain today. I feel it in my bones." And
So there is
and sometimes they're
somewhat
like,
of-
"Actually, well, hey, it's raining right now."
Yeah, yeah.
And I could have looked out the window and saw that and just kind of said something. But
Yeah. So there is somewhat a justification behind what they're
All
saying.
right, excellent. Here we go. I'll take this one. Is it true that you cannot catch lupus from someone or give lupus to another person? That is true. You cannot catch it. Lupus is not a sexually transmitted disease. You can't sneeze on somebody and pass lupus. And I think that's one of the common falsehoods that's out there, misconceptions out there about lupus, is that you can catch it. And I'm like, you're not playing a game of toss on a ball kind of thing. So that's absolutely false. Here we go, Dr. De Silva. I like this one. Is it true, because everybody's doing this right now, is it true that apple cider vinegar cuts pain in people with rheumatoid arthritis?
So false. It's again another one along the lines of the green tea and the copper. It just hasn't been shown in whatever studies that have been done on this, to my knowledge, have been more kind of patient reported. It's not a controlled sort of study, and it really isn't. It matches up with placebo. So about half how much you would expect for patients to respond with just drinking some maybe orangey looking drink versus true apple cider vinegar will have equal responses. So again, if I tell patients, if it makes you feel better, then go ahead and try it, because again, apple cider vinegar it's relatively benign. But if it's not helping you, then I don't know that you necessarily need to make it a habit of having, you know, however much per day.
Yeah, I see some people apply apple cider vinegar to a whole host of medical
weight
ailments,
loss and everything.
and I just quite frankly, haven't seen the evidence. It hasn't been shown. So now I'm kind of like you. If it's not hurting you, if it's, knock your socks off if you want to. But again, if we're going to base things off of some evidence, I do acknowledge that the medical community can be rigid at times. But we're talking about life or death in some of these conditions. An infected tophi from gout can lead to sepsis. It can lead to a lot of things. So there's some indirect stuff, and we're talking about some of these conditions that can cause kidney failure and all things, or blood clots and some of these things. And so we want heart disease. So we're talking about life or death. So we want to use the evidence that the best evidence available to help guide our patients. So here we go. I'll take this one. I like this one. Is it true that fibromyalgia is a middle-aged woman's disease? I'm going to answer it this way. I'm going to say 75 to 90% of women, people with fibromyalgia are women, but there are plenty of men that have fibromyalgia, and actually there's kind of a gender bias on that one on the diagnosis. I think the current estimate's about 1 to 2.5 million men in this country have fibromyalgia, and again, it's a gender bias diagnosis, and certainly for me as a physician, I'm not typically suspecting that, and I think that's hard because I know you probably see men in your practice that have fibro. You want to give a little more commentary on that?
Yeah, so I think just in general, and it's something that you're trying to promote for men to take more control over their health, because when you think about the number of male patients versus female patients, that's already where there's a little bit of skew, right? And so I think also mental health in men is not addressed as much as mental health in women. So women will be quicker to get a diagnosis of depression than it is in a man. I feel like men are kind of told, and it's totally wrong, oh, suck it up, you'll be fine, versus if a woman had the same complaints, it'd be like, okay, here's some medicine, you're depressed. So I think that also plays a role, again, because some patients with fibromyalgia do have that psychologic and mental illness that's not being addressed, that's a little bit of where that skew comes from, in addition to just men maybe being embarrassed or feeling like they shouldn't talk about the symptoms that they're having. Again, it's wrong. They should come forward. They should try to get treated.
I agree. Guys have to be comfortable out there to talk about their feelings, talk about what's going on in this society of machismo. So I can just grind it out. It's got to stop again. If something's going on for a handful of days, because again, we're human, maybe sometimes you can wait about a week or so, but if things aren't getting better, then we certainly want people to act on it and not just stay on the sidelines and stay idle. So here we go. I like this one. Is it true, Dr. DeSilva, is it true that eating what are we called the nightshade veggies, tomatoes, eggplants, potatoes, and peppers can make your rheumatoid arthritis symptoms worse?
So this is actually questionable. Okay, so there are some studies that suggest that there are certain foods that can be pro-inflammatory. So it's hard for me to say specifically nightshades. I know that is a hot topic, as well as, some of the same foods that can be pro-inflammatory or that are high in the purines like we talked about. So red meat and kind of those things, it can be somewhat pro-inflammatory, but at the same time, I wouldn't just say that by cutting these out or by taking them. If you say you had a diet full of just nightshades, I don't think that would be the cause of the rheumatoid. So I would say that when I tell patients who are interested in doing lifestyle changes, I tell them to do any sort of diet change for a solid month, like 4 to 6 weeks, and see if they feel different. If it makes a difference for you, then cut it out. It's not, these are not things that you absolutely need to have in your diet, and you can kind of get protein and some of the other nutrition from other foods.
Yes, you can.
And the other thing I wanted to mention too, along this lines, is also gluten. So a lot of times people feel like they might have celiac disease, they get tested and it's negative. I feel like there still is somewhat of a gluten sensitivity for patients who might not have classic celiac disease. But gluten itself can be really pro-inflammatory, and you touch base on that autoimmune protocol diet, right? So that's cutting out all gluten. I think that, again, diet and even food allergies and things like that play a huge role on how our body sort of just functions on a daily basis and how well we feel. So cutting out gluten as well as maybe these nightshades might not be a horrible idea.
Excellent. I got a question here. I'm going to read it to you. Is it true that people in the tropics don't get rheumatoid arthritis as much? Have you heard anything about from a geographical?
So that's a good question. So there are certain areas that have been shown to have more incidence of rheumatoid versus not. And there is some studies to back it up about the microbiome, which I don't know that we've talked about yet. No. So, in some of these areas or other countries where patients have parasitic infections or other things that kind of affect their gut, sort of the healthy versus the unhealthy gut bacteria, have been shown to actually be preventative against developing rheumatoid arthritis and some other autoimmune conditions. So there are some geographical changes, and it does seem to be linked to not only genetics, but also that microbiome and kind of how that is.
Yeah, I did a show on the gut microbiome with a colleague of ours named Dr. Shivani Kirlik back in May, and we broke that down. And yes, the gut microbiome is so important. I certainly tell people out there to go back on my website, www.drmarcos.com. Check out that show. Highly recommend us breaking down the gut microbiome. So I want to do this. We've been going this awesome. I love this Is That True section, but we got to get into some myths versus facts. Sure. So thank you for those that wrote in on Facebook, so we can get at all those questions. But again, I think you got an idea of really what we're trying to do is just making sure at the end of the day, you talk to your physician, talk to your experts on different conditions to help you out there. Don't believe everything that you read on Dr. Google is true. We want you to talk to real people and find those right resources. So wonderful. But thank you those that chimed in online and everything. So here we go. Myths versus facts. That's what we do every week on Tear Up with Dr. G. And we're kind of already kind of leading into that kind of is this true, but I wanted to kind of make sure we stay consistent with what we do. So again, a lot of misinformation out there. Let's tell the truth. So I may participate in this as well.
Sure.
I like it. I like how this is like the most I participated in like fact and fiction ever on any show of Tear Up with Dr. G because it's you. That's why I did it on purpose. All right, let's do this. Tear Up with Dr. G. Here we go. Myths versus facts. Rheumatologic conditions made ridiculously simple. Here we go. I'll say the statement, and then Dr. De Silva will say myth or fact, and tell us why. We'll do a boom, 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 boom. Kind of go through this. Here we go.
Okay.
All right. The symptoms of rheumatologic disease can be difficult to pinpoint and are often dismissed as just aches and pains. Myth or fact?
Fact, 100%
Please explain.
fact. So a lot of these symptoms can overlap with one another, and that's why it can be very difficult to pinpoint a true diagnosis. That's where blood tests can be helpful, but again, blood tests are not 100% accurate, and so it can be difficult. A lot of times, even like we said, even having a cold or a flu, you're going to have diffuse aches and pains, and you might feel like that. Like you mentioned, having more prolonged symptoms lasting more than 6 to 8 weeks, even 3 months, that's when we worry about something more going on.
Excellent. Here we go. I'm going to do this one, myths versus fact. Here's a statement. Rheumatologic disease is just another name for arthritis, and that is certainly a myth. The reality is that there are over 100 different types of rheumatologic conditions affecting over 50 million people in the U.S., so it's very diverse. It's not just arthritis, and that's one of the biggest myths out there. It's so much more than that, but again, get back to if something's going on, I want you to go see your doctor and have a proper assessment and evaluation. So here we go. Here we go. Myths versus facts. I like this one. Dr. De Silva, this is for you. Rheumatologic diseases only affect the elderly.
Myth. So like we touched base on already, children can get it, particularly younger women as well as men. These autoimmune conditions don't really have any particular age. I mean, there are some associated ages and bimodal curves and whatnot where there's more frequency, but it really can affect you at any age.
Excellent. All right, here we go. I like this one. I'm giving myself these easy ones, and Dr. De Silva's getting the hard ones. Sorry, that's how it works. It's all good. It's like your cable my show. It's all good. Here we go. Here's a statement. Treating rheumatologic diseases is not a one-size-fits-all approach, and I think Dr. De Silva will agree with me. It is true. It's not a one-size-fits-all approach. With anything that we do in health, we certainly want to make it as tailored to the person. We want to be realistic with people too. We want to find out what their goals are when we render them a diagnosis. But we also want to plan ahead. We want to. I know I certainly try to take the time to explain the condition to my patients in plain terms and talk about what's realistic. And I know if somebody's got a pretty progressive rheumatologic disease, again, of course, we're seeing you. But even when they come back and see me and I just kind of talk about lifestyle, but it can be so unique on the person. So they have to be there. All right, here we go. Dr. De Silva, I like this one. Here's a statement. Women and minorities are disproportionately affected with rheumatologic disease. We didn't talk about a little bit of a ethnicity breakdown.
Right. So I was going to say fact-ish. Again,
fact-ish,
right?
okay.
Throw these
That's fine. Please, go right ahead.
So there are certain diseases that seem to be more prominent in certain ethnicities. And again, whether that's a genetic background, it's hard to say. And it does seem like women in general do suffer from particularly rheumatoid arthritis as well as lupus more often than men.
Okay, thank you. Here we go. I'm going to take this one. Rheumatologic disease will go away with time. And I'll kind of say depends, and I'm going to say it depends with an asterisk next to it. If I have a bum hip and I finally get surgery and I got a new hip, I'm feeling pretty good. I don't have any hip pain anymore. But if we're thinking about more the context of things like lupus, yes, lupus is not curable. Rheumatoid arthritis, you're going to be on something, you're going to be in a big game plan. Most people with gout are taking something pharmacologically in addition to the lifestyle. So think of it as more of a lifelong, generally speaking. But if you have a bum knee from osteoarthritic breakdown and you get that new knee, you do your proper rehab.
But keep in mind, if you have a bum knee or a bum hip and you wait too long, that's going to affect other joints in your body. Because remember, you are one body, right? So right hip pain, if you have really bad arthritis, the way you're going to be walking to compensate for that pain is going to cause issues on the other side. So that's my only little caveat.
I love it, Dr. De Silva. I love it. Here we go. We'll do a couple more of these. I like this one. This is an easy one. I love this one. I wrote this one for you on purpose again. I wrote a lot of this stuff for you. Here we go. Here we go. Here's a statement. Your primary care physician will refer you to a rheumatologist if your symptoms indicate a rheumatologic disease. Myth or fact?
I would like to say fact, but there are some situations, again, like we talked about, that some rheumatologic diseases can be managed by the primary care. So I don't want to say always a rheumatologist. And like we talked about, there are other specialties that can be involved, particularly orthopedics, podiatry, and depending on what true rheumatologic disease we might be even talking about, cardiology, like a lung doctor, a kidney doctor, a heart doctor, all of these other things. But again, if you don't mention to your primary care provider what is going on, then it'll be hard for them to kind of get you on the right path and get you to seeing who you need to see.
Excellent. We'll do 2 more of these. I'll take one. I'll have Dr. DeSilva take one. I might go out of order, but here we go.
Sure.
The FDA is currently unable to regulate the quality of herbal remedies and supplements, or to verify their effectiveness or safety. And that is true. There's a lot of difficulty in doing that. The reality is that for a lot of different non-pharmacologic options, certainly like the herbal remedies or the supplements that are out there, the reality is just that clinical trials are lacking. There may be some in vitro anti-inflammatory benefits, but the reality is just we just don't have the data. And this is where I think where you have to talk to your physician to find out how you can best approach a rheumatologic condition.
And just a quick
Please,
thing,
go ahead.
so the NIH actually has information on some of the supplements
Okay.
and some of the things that are somewhat controlled. So
That's
if you
good
have
resource.
questions, that's a resource for patients
Actually,
to
she
look
said
at.
the NIH, National Institutes of Health. Thank you, Dr. Silva. Here we go. The last one, myths versus facts. I like this one. Here we go. I like this. Here you go. Arthritis is an inevitable part of life, so you just have to deal with it.
False, or myth, I should say.
Please explain.
So yes, to a certain extent, by the time we all reach a certain age, we might have some level of arthritis, but we have such control in our lives to try to slow that progression, particularly if you're talking about that wear and tear arthritis or osteoarthritis, by the lifestyle modification. So making sure that we're not obese and that we're controlling our weight. Studies show that 1 pound of being overweight is actually 4 pounds of pressure on your joints. So those are things that you can actively try to change in your life to try to prevent it. And it's not something you just have to deal with. Obviously, we've talked about multiple different treatment modalities, whether it's physical therapy. We didn't get to talk as much about that, but physical therapy, staying active in conjunction with medications to try to help.
Wonderful. So there you go, myth versus facts. So we have just a few moments left, and this has been an awesome show. Time goes by
Great.
fast,
I know,
doesn't
I
it?
can't believe
We're
it.
fun, and we didn't even get through half the stuff, but that's
I
all right.
know.
But it's just been great trying to bring the right information. Been great interviewing you. So
Thank
I
you.
said at the beginning, we talked about the chief complaint. Again,
Yeah.
how do we really correct a lot of the misinformation and separate truly fact from fiction when it comes to rheumatologic conditions? As we're talking about rheumatologic conditions made ridiculously simple, and understanding that, we have the assessment and plan, and that's of course when we make a diagnosis, and certainly we give somebody a game plan, and of course most importantly, schedule a follow-up. So Dr. DeSilva, bring us on home. What are a couple take-home points that you wish people know about today, as our show today about rheumatologic conditions, the realities of them? What are just some take-home points for people to be successful?
Sure. So the main thing, and we've stressed this over and over again, so diet and lifestyle modifications are really important. However, it's not going to completely cure the disease, right? And that's where medications can help be used in conjunction with the diet, lifestyle, and exercise and those kind of changes, as well as some of these supplements. That's one important thing. I want patients not to feel afraid of the medications. They are available for a reason, and we've been able to have so many strides in the world of rheumatology in terms of different targeted therapy to try to decrease some of the really scary side effects. And 2 other quick points, from a primary care point of view too, and for patients, an ANA does not mean you have lupus. Okay,
Thank you for clarifying
so that
that.
is one thing that is a very a huge misconception in the world of rheumatology. So I don't know the exact statistic. I think it's about 1 in 4 women can have a low titer ANA be positive and not even be pathologic at all. Also, thyroid disease, particularly if you have thyroid antibodies, can cause an ANA to be positive. So don't misconstrue that having an ANA that showed up as being positive, it automatically means that you have lupus. That's when you go and talk to your provider a little bit more, or ask to see a rheumatologist to have further evaluation. And the last thing is, we talked a lot about some of these supplements, and I know that there were questions about turmeric or curcumin, as well as these omega-3. You have to be sure that depending on what other medical conditions that you have or medications that you take, particularly blood thinners, that these supplements, even though they're natural, can affect the efficacy of your medications. So when in doubt, if you are doing any sort sort of supplement, be sure to talk to one of your providers and be sure that they're aware of the supplement, and for them to do a little bit of research to make sure that you might not actually have harmful side effects from these supplements and these herbal remedies.
Excellent. Well, thank you, Dr. Silva. And she gave the information for the National Institutes of Health, that they have resources as well. So thank you very much for coming on my show today. I really enjoyed this interview.
Thank you.
And yeah, we got to do something again soon. There's no doubt. We got to do this. We've kind of been a little generalized, but we can get a little specific. But thank you very much. So my final thoughts are this. We're talking about just rheumatologic conditions made ridiculously simple, and I hope that we've given some more clarity to people out there and given them some truth that they can, again, have a conversation with their physician and their loved ones as well. We want everybody to feel better. The reality is this: unfortunately, the symptoms of rheumatologic conditions are often dismissed, or a variety of misconceptions still persist, and that's why we're talking about it. And the reality is that early treatment is most crucial to minimize side effects and improve long-term health. So don't forget that. Always going in to see your doctor. Thank you very much. So thank you, Dr. DeSilva. I want to read her credentials again. She's been an amazing guest. Dr. Nisha DeSilva, board-certified rheumatologist, Edward Elmer's Health. Check her out, www.eehealth.org. You've been listening and watching live on Facebook at intellectualradio.com. This episode is written by Mark D. Gomez, MD, and Tiffany E.R. Gomez. Producer is Tiffany E.R. Gomez. Music is by the wonderful Mr. Havis. Copyright 2019 by MDG Wellness LLC. All rights reserved. Stay tuned for my next episode in 2 weeks. Lifestyle tips for the older population. Again, share this show. Stay well, everybody. Have a great Thanksgiving next week, and catch you guys later. Peace out.